I thought I'll share with you a little bit about lung transplant, the whole process, and then briefly what we're doing with regards to applying this therapy in patients who have cancers. Now, unfortunately, we haven't really been able to, because it's an early stage of kind of looking at it in the context of transplant, we haven't been able to extend it to patients who have small cell lung cancer. But I do think that in the future, as we just help many patients with other types of malignancies, it's not inconceivable that we may be able to help some small cell lung cancer patients also. So lung transplant, this is just a brief overview of the solid organ transplants, how it all evolved. So I've just a fun fact, 1905, when first cornea transplants happened, kidneys started happening from 1950s. These are successful transplants. And then lung transplant, if you go down, 1986 was the first successful double lung transplant ever performed. And then more recently, things like face transplants and such, and people are looking into uterine transplants as well now. Now, I put this slide because this means a lot to me personally. The first, I told you the first successful transplant was in 83, 86, single and double respectively. But the first attempt at human lung transplant was in early 1960s by Dr. Jim Hardy, and actually it predated heart transplant attempts. So Dr. Hardy did this in a patient who had lung cancer. The first ever lung transplant attempt in a human person was done for lung cancer. The surgery itself was deemed to be successful, but the patient at the time, we didn't have the medications that we have now to modulate the immune system. So the patient died of some complication resulting from infection and rejection and such. And then subsequent to that, there were at least 38 attempts at doing lung transplants. They all failed because mostly medical therapies weren't there and surgical therapies were still developing, like the technique. It wasn't until 1981 that Dr. Joel Cooper and then subsequently one of his mentees, Dr. Alec Patterson, successfully performed the single and double lung transplant in 83 and 86 respectively. So these are just some fun facts. First human lung transplant that was attempted by Dr. Jim Hardy. The patient was John Russell. And first successful transplant was on a patient called Tom Hall. He had pulmonary fibrosis, IPF, survived for 7 years. And then the first double lung transplant, 86, was for emphysema for a lady, Miss Ann Harrison. And then, as I told you, Dr. Cooper and Patterson came to WashU and performed the first successful double lung transplant for cystic fibrosis. And that really spearheaded the launch of the field. And now, as you see how rapid the lung transplant field has evolved, the indication for doing transplant has really been growing. So these annual numbers show you how many transplants we are continuing to do, and that's a result of more patients being recognized as requiring transplant, and the indications are expanding. The most common indications are highlighted here, so I'm not going to bore you too much with the details of the graph here, but the common indications are pulmonary fibrosis, interstitial lung disease, cystic fibrosis, emphysema, alpha-1 antitrypsin deficiency, sarcoid, and then sometimes we read transplant. But as you will notice, cancer is really a very small population of transplant, if any, and really represented in this other category. So what happened was lung transplant, as I mentioned to you, Dr. Hardy did the first one in a human subject, but subsequent attempts, even after Dr. Cooper and Patterson performed the successful transplant, even after that, lung cancer was considered as a transplant, and those transplants were not really deemed to be successful. And I will mention some reasons why and what lessons we've learned from them and what we've done at Northwestern now to overcome that and successfully being able to perform that transplants in terminally ill cancer patients. So there's a very high level overview. So typically we have 3 phases of transplant: the evaluation phase, then the actual transplant, and then the post-transplant. So in the evaluation phase, if a patient needs a transplant, they come to our program. They would meet a number of people in the team, not just physicians, but other support staff, including our nurses to do the counseling, our pharmacists, our social workers, our financial counselors. And a lot of testing is done at the time to make sure that transplant is the right thing for that patient. The body can withstand the surgery. So all of that is being determined in the first evaluation phase. And once that is all completed and we determine that the patient needs a transplant, we would then talk to the patient. And once the patient is agreeable to be listed, we will list the patient. So then the patient is on call 24/7, just like us, because the organs come from a deceased individual, that person could be anywhere in the country. So we have to be prepared at all times to be able to do that transplant. So once we get the offer for our listed patient, and all the patients go into this national registry, and all the organs then are allocated by the federal government to respective recipients across the whole country based on the priority score that is calculated by that national registry. So that's not something that the programs do. We would just provide all the information to the registry, and it calculates the score, and the score varies. There's a range from the highest to the lowest. So the higher your score is, the more priority you get for the allocation of the organs. So once we get the organ allocated for the patient, then one team goes out there to the donor hospital, which could be anywhere in the country. And then the team will go look at the organs and then start the process of retrieval of the organs. And at the same time, we would start the recipient side of the surgery, where we take the recipient or the patient to the operating room. We start making all the incisions and those kind of things. Because once we take the lungs out of the human body from the donor, you have about 6 hours or so to be able to transplant them, and that includes extracting the lungs from there, packaging them, transporting them to Midway, and then bringing them to Northwestern, taking old lungs out, putting new lungs in. All of that has to be done within 6 hours. So we have to be very closely choreographed to make sure we are efficient in the process. And then finally, the post-transplant, which is, maintenance of the surveillance, making sure there's no rejection and any complications. So the team then works with the patient to outline all the process. And then the bottom right shows you how the flow of organs works. So deceased donors, someone is brain dead or, has a cardiac event. Those donors are then managed by the countries divided into different regions. Each region is managed by an organ procurement organization, which also called OPOs. And so once they take over the management of the donor, they will inform the UNOS, which is the federal body that I mentioned that controls all the allocation. They will start making the calls to the respective center based on who's listed. And then the center will then, take the organs and transplant their candidates. Very briefly about the surgery. So there is the recipient side that I mentioned, and then there is the donor side. So the donor side of the surgery involves, because that donor is not just donating the lungs, they're donating many other organs, the liver, the kidneys, the heart, the cornea, pancreas, intestines. So many teams from different parts of the country all assemble to that one donor hospital at a time that is determined mutually. And then all the teams go there and then simultaneously start the retrieval process. The implant is a very high level. So there are different types of transplants that we perform. You can do single lung transplant, you can do double, we can do heart and lung transplant for certain conditions. And then occasionally we do lobar transplant, where we take just part of the lung and then implant it. That is not done very commonly in the United States. This lobar transplant is mostly reserved in countries where deceased organ donors are not available. So like Japan and so forth, this is a little bit more common. But we have the ability to transplant the whole organ. So that's what we typically use. There are 3 things that we have to do. We have to attach the airways of the patient with the new lungs. So that's called the bronchial anastomosis. Then the second is the blood flow that we have to establish between the heart of the patient and the new lungs. So there is a vessel, pulmonary artery, that takes the blood from the heart to the lungs that we have to connect. And then finally, we have to connect the veins that attach the lungs back to the heart, so the lungs can put the oxygen in and take carbon dioxide out and return the blood back to the heart. So these are the 3 major things that we have to do in every transplant. At the end, this is how it looks. Most commonly, the incision that we make is called a clamshell that goes below your nipple line. And once we close, this is how it looks. On the right, you see a slight modification of how it may look in a slightly less invasive manner. Now, because there is a lot of need for organs, but there's not enough organs out there, we have used lots of innovative techniques where we can take the lungs out of a donor if they're not usable up front, and we put it on machines. We can repair them and then transplant them. So one of the common techniques is ex vivo lung perfusion. Here you can see lungs coming in a storage, and then we put them on our circuit. And then after that, they are set up in the operating room. You can see this box in which the lungs are contained. They're attached to the ventilator. They're attached to all these machines. And then we are doing x-rays on them, doing bronchoscopies to clean things out, and then hopefully recover them. So with that, I want to quickly transition into the cancer transplants. We call it the Transplant Oncology Program. What predated this idea was our work in COVID patients. So in 2020, we pioneered this double lung transplant procedure for critically ill COVID patients. And this we were the first in the nation to do that. What we found was lungs that were damaged from COVID, they were heavily infected with really lethal organisms. We were able to take them out and carefully, without spilling those bacteria in the bloodstream, and then put new lungs in them. So this is just an image of how COVID lungs look like. You can see there is complete destruction in the video. And I'm going to go back here. So this first video shows your normal lung, which all this intricate fibers and what we call the scaffold. So it's like a building. You take the drywall and the paint inside, you'll see the network of cables and everything like that. That's what the basic framework of the lung looks like. But what we had found based on our work and research, that COVID in some patients caused pretty profound damage. And here you can see a COVID patient, see that basic framework was destroyed. So transplant was the only option. So we had recognized that early on and performed the first transplant. But the lesson that we learned was this could be highly successful even in patients who are critically ill, who are mostly been on a ventilator for weeks and weeks on ECMO machines. They've had a number of complications and their lungs are full of lethal bacteria. So we can still, even in those critically ill patients, we can carefully remove the lungs without spilling those bacteria into the bloodstream and then save these patients. In fact, in this scientific curve that you see, the orange line on the bottom, we had no mortality up to 1 year in these patients who would otherwise die. And we did a number of these transplants successfully. You see, these are just some examples of COVID lungs, how destroyed they were. And that was a big lesson that we learned during the COVID that helped us then extend these principles to patients who had extensive cancers in the lungs, particularly non-small cell lung cancer is what we started off. And the idea was you have these patients who have failed all these multiple lines of therapies, and the cancer has almost completely replaced their lungs, and they're critically ill. So can we use those same principles to help these patients to take out the cancer from take out both the lungs without spilling any cancer into the bloodstream and put new lungs in them? Now, that was based on the basic ideology that the cancer has to be limited to both lungs only. Right now, we are exploring certain strategies where tumor may be present at certain other sites, so we can clear the main cancer in the lung by transplanting and target the other sites using targeted therapies, but that's not for prime time right now. So currently what we are doing is lung transplant only for cancer that's limited to the lung. This is kind of the summary of the program that gave rise to this idea. Ultimately, it's called the DREAM program. So it stands for it's an acronym which I've put on the top of the slide: Double Lung Transplant Registry applied for lung-limited malignancies. So that DREAM program then was done as part of an observational study. So this is only offered at Northwestern, only place in the world, to the best of our knowledge. Certainly no other place in the country is offering it. And This is a barcode. If someone wants to take a snapshot, it takes you to the clinicaltrials.gov registry where you can look at all the inclusion-exclusion criteria. But essentially what the steps are here are the following. So we go through, in addition to the process that I outlined for you for lung transplant patients, the ones that have chronic conditions, not cancer, we add a few additional things here specific to cancer. So we have to do the staging workup, making sure that the cancer is not outside the body, chest cavity. We perform some lymph node evaluation with mediastinoscopies and stuff like that. We perform liquid biopsies, and sometimes we put in cameras in the chest, make sure that the tumor is confined within the lungs. And then once all of that is done and they meet all the criteria, then they go through the double lung transplant process, just like what I described to you before. But it's a little nuanced because we've developed a unique way of doing this, and I'll show you a quick video of that, where we are able to first take out both the lungs and then clear the chest by really thoroughly washing the chest cavity with our reagents to clear out every cancer. Normally, the transplant is done where we take one lung out, put one lung in, take the second lung out, put the second lung in. But we developed a way to taking both the lungs out concurrently and then putting new lungs in. And that is done to really reduce the chance of it spreading from one lung to the other. Briefly, what I wanted to highlight were the three conditions that have to be met for patients to be eligible for this. First criteria is that they have currently the cancer has to be limited to the lungs or the chest cavity. It shouldn't have gone outside the lungs and the chest cavity. The second is the patient should have failed all the standard of care cancer treatments, because we always believe in giving the cancer-specific therapies first, and if everything has failed, then we would consider the patient for the transplant. And the third criteria is that they should still meet the general criteria for lung transplant that I was alluding to in the prior slide. So those are the three broad criteria. And the three cohorts of patients that we are looking at, cohort A, B, C. Cohort A are patients who have lung cancer that has spread to within the lungs. Let's say a tumor comes from left side, goes to the right side. It's stage 4 because of that, and they failed all the treatments. Cohort B are cancers that are they originate outside the lungs. So, like for example, sarcomas or colon cancers and variety of other cancers that have gone to the lungs. The main cancer has been cured, but the lung metastasis, because see, lung is the most common site of metastasis for all cancers. And there's no cancer that cannot go into the lung. So it's a very, very common site of metastasis, and many patients ultimately die of lung metastasis. So cohort B is designed to help patients who have cancers outside the lung, but they are metastasized to the lung, and lung is the only site of disease. And cohort C are patients who had cancer within 5 years, had cancer cured, but then as a result of therapy, they've developed disabling respiratory failure. Like immunotherapy is known to cause lung pneumonitis and respiratory failure, or patients who may have had respiratory failure before and then they've cleared the cancer and now they need a lung transplant. So conventionally, within 5 years, no one transplants these patients, but we think that based on our strategy and our processes, we can help those patients. So I'm just going to end by showing you a couple of examples. This is a 61-year-old never smoker, had a lobectomy in 2018 at a academic medical center, and had multiple different therapies, as I've listed on the left side of the screen. And for those of you who may be familiar with CT scan, you can see how extensive this disease is. The CT scan shows you the right lung and the left lung. And I'll go back here. You can see all of this white stuff. This is all cancer. And now the bottom scan, you see it's a post-transplant scan. About 6 months later, you can see there is no evidence of cancer. And by all the testing that we've done, patients living a normal life without evidence of cancer. This is just an example of what I was showing you. So here on the left side, you see, and I apologize, this might be a little too graphic for some people, but I just thought I'll illustrate the point. This is an intraoperative picture of the technique that we've developed. So on the left side, you see the heart with all the cannulations, and both the lungs have been taken out along with the cancer. We've thoroughly cleared all the cancer cells. And on the right, I will play a video for you. This is how we are irrigating using our reagents, the airway, to flush out any remaining cancer cells in the central airway. So, lastly, just to show you kind of what the outcomes have been looking like with over 2 years of doing this, these are the first two patients. On the top left, you see how extensive this cancer was. And Albert, you see the whole lung is replaced. These are all dense cancers. He's living a normal life, cancer-free, over 2 years out. And this graph on the top shows you 100% survival to date with no cancer, everybody cancer-free and alive. And these were all, mind you, they were stage 4. They were put on hospice care at the time, and they really had few days to live. Lastly, we are very excited about this, and this is an example of the cohort C that I mentioned. This is the first multi-organ transplant ever performed to the best of our knowledge in the world. This patient had a double lung and a liver transplant. Patient had a very extensive right lung cancer, went through many lines of therapies, but those therapies resulted in somewhat shrinkage of the tumor, but the lungs developed respiratory failure and liver developed cirrhosis as a result of the therapy. So on the top CT, you can see how bad these lungs look. They have all this fibrosis and everything from radiation and immunotherapy. And bottom is the new x-rays and, so forth. So he's about 3 months out, multi-organ transplant, cancer-free, getting stronger every day. So I want to finish by concluding that we are very optimistic about this therapy, and hopefully with lung transplant development of new therapies for cancers, we'll be able to help a lot of patients who have otherwise no other hope. And I would just end by just asking your support in continuing to promote awareness about lung cancer, particularly getting patients into screening as soon as possible. Colon cancer is almost half as prevalent as lung cancer. Lung cancer, as you all know, is the biggest killer of all cancers in the country. But everybody goes to colonoscopy, but we don't have a universal lung cancer screening process. So you have a cancer that is twice as prevalent and twice as lethal, but we are not doing enough for screening. So whatever you all can do to promote awareness for that. We have a lung nodule clinic and a lung screening program, not just for patients who meet the criteria, but we have mechanism to screen patients who may not meet the conventional criteria. So we are happy to partner and help you. So with that, I'll stop and happy to answer any questions.
I think you answered the first one. So what about patients with metastatic disease? And you basically said as long as it's confined in the lungs, correct?
That's correct. Yeah.
Okay. I saw that you had something up there about the requirements for donors, but I wasn't sure about, for example, if somebody ever had a cancer diagnosis, does that disqualify them from being a lung donor?
No, that's not true. So at the time of lung donation, or organ donation, we would assess, what the situation is. But just having a history of cancer does not automatically preclude someone from getting an organ donor.
And let me ask you this. I've known a few folks who had lung cancer transplants. This was maybe, 12, 13 years ago or more. And their cancer returned to the lungs, even though they had no history of smoking, and yet they got the double lung transplant. And the cancer came back in all three of those patients. Is this a common occurrence for the cancer to come back?
Yeah, no, great question. And I think I, in the interest of time, didn't have the opportunity to show you all the prior work that has been done. But the thing is, there have been 3 broad principles that we've applied that we think will play a big role in not having or greatly reducing the chance of cancer coming back. And we have not seen, like I said, so far over 2 years, we've had 100% survival.
Wonderful.
And so now in the past, the survival was less than a year in many patients, or in 2 years, they were all coming back. But the many important principles that we've applied, one is the surgical technique of taking both the lungs out and putting new lungs in fresh and washing out so that was never done before, which we've developed, which I think will play a big role in preventing the seeding. The second thing is our ability to screen patients for cancer, extent of cancer outside the human body. Also, the chest cavity is much better. We are doing a lot more thorough staging and, making sure that we don't subject a patient who has extensive disease outside the lungs to the transplant. And the third thing is we never transplant patients without them having received systemic therapy. So in the past, many of these patients went straight up for transplant. So what had happened in those patients was any microscopic disease outside the lung was not treated, and they did the transplant, and there was a lot of recurrence after that. So those are some of the principles that we've applied, which I think will play a big role in long-term success with the way we are doing it now.
That's wonderful. Let's see, another question. This is from Maureen. And so Maureen has stage 4 lung cancer. It's limited to her lungs. You had surgery and radiation, but no systemic treatment because you are KRAS G12V. Is that correct, Maureen? Jump in if I misread that.
I think the doctor just answered that, though. You have to have systemic treatment to be considered. They don't think I need it.
I see.
But I am stage 4, so that's...
If you're stage 4, why are they saying you don't need?
Because they are so small and it's only confined to the lungs, that they don't feel I need systemic treatment.
Yeah, obviously I don't know all the details about your situation, but I think you should definitely talk to them, or we are happy to look at your case and tell, because that, to me, there is a little bit of a inconsistent. Even though your cancer may be small, for stage 4, you should not be not getting a therapy because they tend to very rapidly.
Right.
So.
Right. I did go for a second opinion because I couldn't wrap my head around that either. And then said the same thing for the second opinion.
Maybe because of the biomarker, the
right, the biomarker, there is no targeted therapy for it. Right.
But you should still be able to get the standard chemotherapy.
Right.
Even if you don't have biomarker, we'll have to look at your PD-L1 expression. But if you've never had systemic standard chemotherapy, you absolutely, just having a KRAS or a mutation doesn't exclude you from that. So anyway, if you feel the need, happy to, I can share with the group my email. Feel free to reach out, but we're happy to have you.
Great. Thank you very much for that question, Maureen. And please keep us posted too. So Maida has Maida has a question. Is this only offered to non-smokers? And if I may, maybe tag on to her question about that. Is it only offered to never smokers? Or is it offered to former smokers and or current smokers? If you could address that.
No, it's offered to everybody, as long as even current smokers, as long as they quit smoking. So the thing is, as a requirement for lung transplant, they have to commit to non-smoking. And an active smoker who's stage 4 is generally not something that we would consider for transplant because they have to be committed to quitting. But it's okay if they've smoked in the past.
Sure.
Yeah.
Thank you for that. Let's see. Elisa asked about, is systemic therapy required for adeno in situ BAC, which is, if it's so early, they don't need to have a systemic chemotherapy treatment, right? Or would you not qualify for a transplant because you could just remove it?
Yeah, if you can remove it, we always try to remove it rather than subjecting them to transplant. If it can be cured by either systemic therapies or local therapies like surgery, radiation, we always want to try to avoid transplant. But if you get to a progressive disease, it doesn't also have to be stage 4. It could be pretty extensive, stage 1, 2, 3, or stage 3 disease, right? I mean, so in patients who have, let's say, someone had emphysema and then develops a very large tumor, like what happened in the multi-organ transplant, as I mentioned to you, the patient did have emphysema, develops a 10-centimeter tumor on one side, and he was being treated and then develops respiratory failure. So we did a double lung transplant. The systemic therapy, if you had, let's say, in the cohort C that I was telling you about, so if you had a stage 1 cancer that, you had full treatment and that didn't respond and you are in respiratory failure, you don't need systemic therapy for that. Systemic therapy is only for stage 4 cancers that we are trying to do lung transplant on the cohort A. So I personally, I think, these are obviously medically nuanced decisions and discussions. What I would say is just remember those three broad principles. Number one, is it limited to the lung? Number two, has your oncologist and your cancer care team has given you all the standard of care treatments that are available? And if the answer is yes, then please call us and we can kind of evaluate the rest of the situation.
I have small cell lung cancer, so obviously none of this applies to me at this time.
Yes.
But did you say that there are studies going on now to see if anything if a transplant in the future will be possible for small cell lung cancer?
Yeah. Internally, we are discussing that, trying to see how we can further extend that. I don't think any other center, to our knowledge, is looking at that, just us. I think it may be possible in the imminent future. We are just not there yet because we don't have a full handle of applying transplants into small cell situation.
Okay, so I'm glad I live in the Chicago area.
I had a couple of questions. One was, how many patients with lung cancer, stage 4 lung cancer, have actually had the double lung transplant? And the other one is, out of the patients that have had the double lung transplant, how long have they survived?
Yeah, at our center, we are approaching 10. Like I said, the oldest one is just over 2 years ago. So September 2 years, so 2 years and like 3 months. And so we've been very selective. We are evaluating a lot of patients. Now, prior attempts I don't know historically how many have had. There been, I believe, at least 80 to 90 in the past with mixed results before, we learned all these lessons. And so at our program, we've done in the whole DREAM program about 10, closing about 10 so far, and they're all done really well.
Yeah, I know about that requirement that you have to relocate to Chicago for a year.
Yeah.
And I was just kind of wondering why a year and why that's just part of the program itself.
Yeah, the thing is these are obviously, patients who are very sick, like, yourself. And so post-transplant, because as I mentioned to you, we are the only program that offers this. The issue is the first year is very critical in looking for recurrences or, managing any potential issues that happen. And because other centers don't have any experience with this right now, we think it's going to be very difficult to have early recognition of problems and stuff like that. So 1 year is what we've collectively decided. There is also a regulatory requirement that we have to have a very close follow-up for all our patients for at least the first year. After that, we can relax. Now, it doesn't have to be exactly in Chicago. We work with the patients and their families to potentially be in the suburbs or, within kind of a reasonable distance that they can come to us if there is an issue. And they can also maintain the protocols for post-transplant, surveillance and just follow up. If you're in a different state and a different, far away, then you cannot come for all those regularly scheduled appointments that are essential in the first year.
Doctor, how about payment? Is this covered by insurance or is there any any support for a patient to relocate or anything like that?
Yeah, so it is covered by insurance. We work with insurance companies. This got to be fully covered. We work with a number of patients with Medicare, private insurance. There's never been an issue so far. And then, like I said, the organs are then allocated by the federal government, so they will determine all of that. So it's all fully covered. As far as financial assistance, we work with the patient. We have our social workers that are quite connected. We try to provide. We also have some philanthropic funds to help patients in a small. And then we try to work with local philanthropic organizations to provide whatever financial relief. We've also helped many patients create, these GoFundMe kind of initiatives, raise funds for their behalf that go straight to them. So we've done it many times. It's been quite successful. We've had long history. When COVID happened, patients are coming to us from all over the world, and we needed to figure out a mechanism to help patients. And obviously, in those circumstances, patients were really unprepared, and COVID really put lots of other hardships. So I think we've done reasonably well in trying to help those patients from that perspective. It's not perfect, obviously, as you can imagine. It may not always meet every single, need of our patients, but we do try, and I think we've done a reasonably good job. So we actually have a patient assistant fund, part of the Canning Thoracic Institute, that we use to help whatever we can.
Thank you so much. Any other questions?
Actually, Dr. Bharat, before you leave, I do have one question for you.
Uh-huh.
You're here because of one of our small cell lung cancer caregivers in Poland, and I know she's not here today, but in Poland, do you happen to know if this treatment is being taken outside of the US, or?
No, not yet. It's such a new paradigm in there. But so I think ultimately we hope we are partnering with other centers within the US. I'm not at a liberty to disclose just yet, but we are trying to partner with few centers both on the East Coast, West Coast, because we understand the financial hardships and logistical hardships for patients to migrate to or locate to Chicago. Actually, one of the centers just has agreed. So hopefully once everything gets processed, this is more on the East Coast. But we are trying to be the ambassador where we can extend this. We've made some trips to the Middle East. I'm actually going to Asia to try to share this and help partner with some centers that can do that there. So it's going to take some time, but we hope it can become more of a global paradigm for many patients who are in the same situation.
Well, Doctor, thank you again so much for this. This is really exciting, and I'm probably going to reach out and ask you some more information at a later date, but this is great, and I love what you're doing. So thank you so much.
Yeah, thank you for having me. And once again, I wish and pray particularly for all the patients who are on call. I pray that everything goes well, and all the therapies work, and stay strong.